Dr. Rupak Kanti Biswas. He'll be speaking to us on his favorite topic, that is retinal autograft in macular hole. He has devised a lot of various techniques for that.
Yeah. I would like to thank AIOS for the opportunity. But see, actually, the initial discussion was there, ki whatever you can put into the macular hole, it closes. But believe me, this is not a dustbin or this is not a garbage bin that you can put anything and then you can come out of that. Yes, you can close it, but yes, you need to, if you throw something dirty into it, it will smell. So let's see what is happening if you put the right thing at the right place. So I'll just show you a video. You all have seen this is it is a failed macular hole. So where you can just plug in with the residual ILM and free flap and just put it there. So and we'll show you. There are multiple publications are there that the internal ILM plug and gas tamponade causes a persistent and recurrent macular hole closure. Yes, it does. And this is, you can go to the literature, multiple. Treatment of large chronic macular hole with, internal ILM with transposition and tuck technique. Multiple technique has been described. I'll just go through, flip through of modified foveal advancement technique along with, ILM plugging along with or without that. Lens capsular flap also has been put. Manish is here. Manish has done a significant number of cases and published also. Human choriotic membrane, which he has described today morning, Dr. Darius. I'll show you now. Here, if you notice carefully, so all these cases was actually causing a scar here. So if you notice it here. And I'll show one of my ILM plug. Here, this is the case where you can see. Can I get the pointer? So you can see actually it is closed. The macular hole is closed, but everything is totally scarred tissue, which is neural tissue, not matching with the neural tissue. So that's how it is a closure and a successful closure or a functional ability of the tissue. That is the most important what we are looking for the visual improvement. So, and there are another technique has been described for the platelet-rich plasma vis-a-vis inverted ILM peeling for large macular holes. Here also from Arvind, but here also it has been shown that both the technique is equally effective to close the macular hole. But the question comes how the visual functional ability improves or not. So now question comes whether we should put a neural tissue there itself to close the hole and to have the functional ability of that place. So this is a technique which is, I'll just describe you. This is a failed retinal graft where, this is a macular hole surgery has been done, and then this is the recurrent macular hole which has developed RD along with that. So this has been, the nasal retina has been chosen, and it has been cauterized, and this flap has been, well taken according to the size of the graft, and it has been put here. Now the question comes, if you have cauterized the margin and you put this retina here, then this margin is actually ineffective margin. This is a dead tissue which is lying there, and it is once the neural tissue which is come in contact with that, one side is have the neural tissue, the other side is having the dead tissue. So yes, it is also functionally, it will have a functional closure, it will have the anatomical closure, but functional ability, again, still we have a doubt. So to avoid this, what I have designed is actually kind of a trephine, which according to the size of the failed hole, and then you increase of 15 to 20% of the size of the hole, and then select that particular trephine. And this was around 450 size of failed hole size, so I have used 550 micron, and then I'll show you this is a vitrectomized eye, so after that you can just safely go inside the eye and do a trephine, or in a particular, this is I have chosen on the superior, supratemporal area just beyond the arcade area. This is trephination done under saline, and once you, this is the graft, you can see it very clearly, holding in my left hand, and then I did fluid air exchange, and when I'm placing the graft, so that you are holding the graft at one place, and then placing the graft under air, so that there is no change of the position of the upside down or anything. So you just simply place it there, and I'm just tucking it at the margin very gently. You can tuck those margins with the soft tip cannula, and the rest of the fluid you can take out with the flute needle and laser the donor area and come out with the gas. Now I'll show you what I was showing you earlier, that how different it is. Now this is a failed hole which has been closed, and this is the internal limit. This is the graft area, which have somehow to some extent similar tissue, which is even we have the better anatomical structure which has been described in the literature as well with this macular hole. And how functionally effective, now the question comes. So this is the same case which has been done by multifocal ERG, and it has showing a significant spike at the macular area. So the graft is actually functioning with MFERG proven, and we didn't have the the microperimetry, so we did 10-2, and actually if you see the 10-2, the central area foveal threshold is almost 25 to 29 of decibel, so which is significantly good of those area of that particular graft area. So now the question whether the graft is surviving or not. So the vascularization and the reperfusion of that autologous retinal graft is most important. I'll give you some classic example, which is OCTA has fluorescent angiography, and OCTA has been done, which has shown in a successfully closed macular hole with the retinal graft, and the graft has also taken up quite well. With the central area vascularization is not there, but the marginal vascularization is there. So that's how you have the multiple choices, that you need to choose the correct one to prove it.
I think excellent presentation. The trepines go through the 23 gauge, or which gauge, or you have to do a proper sclerotomy?
Yeah, as of now, this has multiple sizes of trepine, which is you have 400 to 1,000 size of micron.
What gauge is it? We require sclerotomy?
No, you need to enlarge one sclerotomy, and as per the size, it will go there. So it is not. It is a fixed size of the tube which goes there, and it has a. So the next question comes whether you are going to injure the choroid or not when you are trefining it.
True.
I'm sure this is the next question is coming to your mind. No, it does not cause. There is after 350 micron, there is a stop inside that trefine. So the margin, this has a two tube inside. So one is the outer tube which is trefining, and the inner tube which is preventing to go to the choroid. And actually, practically, there is the tissue fill is completely different of a retinal tissue fill and the choroidal fill. So you cannot.
Last question by Dr.
Rupak, when you did the trefine, I noticed you didn't do any diathermy or laser.
No.
You just went directly.
Yes.
So do you, after you remove it, there could be a bleeders. Would you go back and diathermize? We didn't see you do it here.
Yeah, after that, you can do the diathermy if there is a significant bleeder.
So
but most of the time, due to that crush effect, what you are trefining, it's the finer tissue, finer blood vessels. So they get usually closed. Otherwise, I'm doing the laser also surrounding.
Great, doctor. Thanks.
In your series, like all the holes closed, and what is the functional outcome?
Yeah, all the holes means initial 2 cases, which I have not used the larger size of the graft. I used the same size of the graft. That was my failure in first 2 cases, which I have a graft regression and smaller size, and one has the subretinal migration of the graft as well.
Thanks, doctor.
So, Rupak, one question. Would you do an amniotic membrane graft in your cases, or you continue doing your technique?
No, I will, as of now, I will not do, because I have the enough proof that yes, this is a neurotization is occurring, the vascularization is occurring, and this is functionally effective. So I have an option which is, all the purpose of putting the macular hole and closing the macular hole is surviving. So visual improvement, closure of the anatomical closure of the hole, graft bivalval, and neurotization. So all the proof is there. So this is the,
So we'll request the next speaker who's there, Dr.
Thank you.
Tarek.
Thanks a lot.